Today, we are zeroing in on some really significant steps forward in interventional cardiology from 2024. We're drawing from the European Heart Journal's top 10 papers list.
Yeah, it's a great summary. Really captures the cutting edge. Things are moving fast.
Absolutely. So think of this as your briefing on the latest ways we're tackling heart disease.
From blocked arteries to valve issues. Yeah, lots to cover.
And look, if you're a cardiologist listening or just deeply interested in this area, you really should check out Evidence-Based Cardiology Talks.
Oh, definitely.
It's a podcast made specifically for cardiologists, goes deep into new publications, all the relevant journals. It's supervised by Dr. Caroli. You can find his site at drcaroli.com.
Great resource. They're on Spotify, YouTube. Well worth subscribing if you want more detail than we can cover here.
Exactly. So today we'll touch on some key findings that, well, listeners of that show would definitely find interesting. We'll hit coronary interventions, cardiogenic shock management, those percutaneous valve therapies.
And even pulmonary embolism interventions, which is a rapidly growing area.
Right. Okay, let's dive right in. Coronary interventions first.
Sounds good. So the big news from the guidelines, the 2024 ESC guidelines for chronic coronary syndromes, is the continued emphasis on functional assessment.
Meaning FFR or IFR.
Exactly. Fractional flow reserve or instantaneous wave-free ratio. It's now a Class IA recommendation before you intervene. Basically, solid evidence says measure if that blockage actually limits flow first.
So it's not just about seeing and narrowing anymore. You have to prove it's causing a problem functionally.
Precisely. And interestingly, even if FFR or IFR looks okay, the guidelines now suggest a thorough functional investigation if you still suspect something else.
Like vasospasm or microvascular dysfunction.
Yes, exactly. Problems with the smaller vessels or artery spasms. That's a Class IB recommendation, so still strong support for digging deeper in those cases.
Makes sense. Get the full picture. And related to seeing more, what about intravascular imaging? IVUS.
Ah, yes. IVUS guidance for PCI stenting also got upgraded.
Yeah.
Class IA now, especially for complex stuff.
Complex like bifurcations, left main artery.
Right. Bifurcations, left main disease, long lesions. Using that ultrasound from inside the artery really helps guide the procedure.
So we're seeing inside the vessel wall, not just the shadow on the angiogram, which it kind of leads into these newer concepts, right? Leave nothing behind, vessel uncaging.
And the growing interest in drug-coated balloons, DCBs.
Okay, so what's the evidence there?
Well, take the Ultimate Third trial. They looked at IVUS-guided DCB for brand new lesions, ones not treated before.
Yeah.
They found it reduced late lumen loss, that's re-narrowing at 7 months, and fewer target missile failures compared to just using angiography to guide the DCB placement.
So that internal view helps, especially with DCBs.
It seems so. And then there's the DCB-BIF trial. That focused on those tricky bifurcation lesions where the artery splits.
Always a challenge.
Definitely. So in cases where they stented the main vessel provisionally using a DCB in the side branch, well, it led to significantly lower MC.
Major adverse cardiovascular events.
Right. Mostly driven by fewer myocardial infarctions, fewer heart attacks, compared to just using a standard balloon in that side branch. That was in nearly 800 patients. Pretty solid.
So DCB is showing promise in complex situations too. It feels like the trend is towards more precision, less metal maybe.
That's part of it. Precision guided by function and imaging and exploring alternatives like DCBs were appropriate.
Okay, now for something potentially, well, revolutionary. The PREVENT trial.
Yes, PREVENT. This tackled a really interesting question. What about treating vulnerable plaques before they cause a major problem?
These are plaques that look nasty on imaging, high plaque burden, thin cap maybe, but aren't actually limiting flow yet. FFR over 0.88er.
Exactly those. High-risk features on imaging, but functionally not significant at that moment. The trial asked, should we treat them proactively?
And the answer was?
Well, the results were pretty striking. In over 1,600 patients, doing preventive PCI on these plaques, plus optimal medical therapy, led to significantly lower MCV rates at 2 years compared to just medical therapy alone.
Wow, so preemptive strikes against heart attacks, essentially. That could really change things.
It really could shift how we approach early coronary disease if this holds up and gets integrated into practice. Big implications.
Definitely one to watch. Okay, let's switch gears. Cardiogenic shock, always a tough area.
Incredibly tough, and the Danger Shock trial addressed this head-on, specifically in patients with a big heart attack, a STEMI, who then go into shock.
Where the heart just can't pump effectively. Life-threatening.
Absolutely. So they looked at routinely using a microaxial flow pump, like an Impella device, these small pumps that assist the heart.
Compared to standard care.
Right. And the finding was significant. Using the pump routinely was associated with a lower mortality rate at 180 days.
That's a real win in such a high mortality situation.
It really is. A major finding that could influence guidelines for managing these very sick patients.
Encouraging news. Okay, moving on to valves. Percutaneous valve therapies are exploding, aren't they?
They really are. Lots happening. Let's start with aortic stenosis, the narrowing of the main heart valve. Notion 2 looked at TAVI versus surgery.
TAVI being the transcatheter valve replacement, SAVR being surgical replacement. But this was in younger patients, right? Under 75.
Correct. And it included both standard tricuspid valves and the less common bicuspid valves.
So what did they find in this younger group?
For patients with the typical tricuspid valve, the outcomes, death, stroke, rehospitalization at 1 year were pretty similar between TAVI and surgery.
Okay, comparable.
But for those with bicuspid valves, the TAVI group actually had more of those negative events.
So the valve's specific shape might influence the best choice, especially when you're younger.
It certainly seems that way. An important nuance.
And sticking with TAVI, what about notion 3? That looked at patients getting TAVI who also had coronary artery disease, right? Blocked arteries.
Yes. The question was, should you also fix those coronary blockages with PCI when you do the TAVI? They looked at narrowings that were functionally significant, FFR less than 0.80, or looked really tight, over 90% stenosis.
And does doing both help?
It appears so. The trial showed that doing the revascularization, the PCI, along with TAVI, resulted in a significantly lower rate of MACE over about 2 years of follow-up.
So treating the valve and the pipes seems better if the pipes really need it.
That's the takeaway, yes. Address significant CAD at the time of TAVI.
Now, early TAVR. This one feels like another potential practice changer. Asymptomatic severe aortic stenosis.
Right. The big debate. Patient feels fine, but the valve is severely narrowed. Do you wait for symptoms or go ahead and fix it?
What did early TAVR show?
It showed that TAVI was actually superior to just watchful waiting or clinical surveillance. Lower NC rates in the group that got TAVI earlier.
So intervening before symptoms might actually prevent bad outcomes down the line.
That's what the evidence suggests. It really challenges the traditional wait for symptoms approach for severe AS.
Very interesting. Okay, let's move to the mitral valve. The Matterhorn trial. This compared TEER,
Transcatheter edge-to-edge repair, like MitraClip,
with mitral valve surgery for secondary mitral regurgitation in heart failure patients. So the leak is because the heart muscle is the problem.
Exactly. And Matterhorn found TEER was non-inferior to surgery for efficacy fixing the leak and improving outcomes related to it.
But the key difference was
Safety. TEER was superior for safety. Fewer complications compared to open heart surgery in this often complex patient group.
that's a big deal for these patients. Less invasive, just as effective, and safer.
It's a very compelling result for TEER in secondary MISTER.
And briefly, the tricuspid valve. TRIA-FR.
Yes, presented at ESC 2024, not fully published yet. But initial results suggest that tricuspid TEER, the edge-to-edge repair on the tricuspid valve, added to medical therapy, helps improve symptoms and reduce the leak severity in patients with severe symptomatic tricuspid regurgitation.
So more options emerging for the forgotten valve, too.
Definitely. More focus on the tricuspid now, which is great.
Okay, last area. Pulmonary embolism, PE. Interventional treatments are really emerging here.
They are. The Peerless trial is a key one. It compared 2 catheter approaches for intermediate risk PE.
Intermediate risk meaning not immediately life-threatening, but not minor either.
Correct. They compared large bore mechanical thrombectomy, LBMT physically sucking out the clot, versus catheter-directed thrombolysis, CDT infusing clot-busting drugs right at the clot. Around 550 patients.
And the winner was?
Well, it depends how you define winner. LBMT, the mechanical removal, had a significantly lower rate of the primary composite endpoint.
Which included?
Things like clinical deterioration, needing ICU care after the procedure. So LBMT seemed better at preventing immediate worsening or needing intensive care.
But what about mortality? Did it save more lives?
That's the important caveat. The trial did not show a difference in mortality between LBMT and CDT.
Okay, so mechanical thrombectomy might stabilize patients better initially, reduce ICU stays perhaps, but doesn't necessarily translate to better survival compared to delivering lytics directly, based on this study.
That seems to be the message from Peerless, yes. It highlights that while these PE interventions are promising, we're still figuring out the best approach for which patients. The evidence is still evolving.
Makes sense. It's a complex area.
Absolutely.
So, wrapping up this deep dive into the 2024 EHJ Top 10 for interventional cardiology. Wow. We've seen refinements in PCI with more focus on function and imaging.
New possibilities with DCBs and that potentially groundbreaking prevent trial concept.
Plus, real progress in cardiogenic shock management with danger shock.
Expanding options and evidence for transcatheter therapies for aortic, mitral, and even tricuspid valves.
And these emerging catheter-based treatments for pulmonary embolism, even if the picture isn't fully clear yet.
It really paints a picture of a field that's constantly innovating, constantly pushing to find better, often less invasive ways to help patients.
It certainly does. And again, for you listeners who are cardiologists or just want that deeper level, do check out Evidence-Based Cardiology Talks. Spotify, YouTube, supervised by Dr. Caroli at drcaroli.com. It's an excellent resource.
Definitely recommended.
So a final thought to leave you with. Reflecting on all this rapid progress we've discussed, how do you think these strategies will continue to evolve? What might the truly transformative impacts be on patient care in the next, say, 5 or 10 years?
It's a fascinating question. The pace is incredible. I think we'll see even more personalization, more integration of imaging and physiology. It's an exciting time to be in the field, that's for sure.